Hello and welcome to our presentation today. This is Dr. Thomas, and today we are doing a pharmacological review on anticoagulant medication. So we're going to look at types, mechanisms, indications, side effects, nursing consideration for anticoagulant therapy. We'll start by defining what anticoagulant medications are. These are meds that are used to prevent blood clot formation. What is scientifically referred to as thrombosis. They are also used to stop existing clots from getting bigger. Remember, this is different from other meds that are used to dissolve blood clots, and those will be the thrombolytics, which we have already looked at when we were reviewing the management of pulmonary embolism, especially massive emboli. So these anticoagulants, they are only used to prevent blood clotting formation or stopping the existing one from becoming bigger. So this topic will be relying mostly on the blood clotting factors, and I hope you still remember the 13 blood clotting factors that we need to know, starting from fibrinogen, which is 1, prothrombin, tissue factor, calcium ions, which are factor 4, labile factor, stable factor, antihemolytic factor A. Then we have the Christmas factor, the Stewart power factor. We have the plasma thromboplastin incident, the Hedgemon factor, and lastly the fibrin stabilizing effect. You can be able to see their alternative names and their functions. So these anticoagulant medications are broadly classified into two. They are subclassified into two. We have the parental anticoagulants and the oral anticoagulants. So the parental anticoagulants, we have the traditional ones that we know, the unfractionated heparin, low heparin molecule weight heparins like enoxaparin. We also have the direct thrombin inhibitors like the lepirudicin, which are the new drugs. Then we have the oral anticoagulants, starting with the traditional ones like vitamin K and antagonists, right? And then we have also now the new ones, the direct oral anticoagulants, right? They are the novel drugs, the new category. If you try and look at the first one, the traditional one, the unfractionated heparin, abbreviated as UFH. This is normally given initial IV bolus at a prescription of 60 to 40 units per kg with a maximum of 5,000 units IV bolus start. Then the maintenance infusion, you give 12 to 15 units per kg per hour, approximately 1,000 units per hour. So duration will be based on the clinical conditions, like let's say it is DVT or the pulmonary embolism, you will be forced to give for about 5 to 7 days. So for monitoring, you normally look at the APTT, and it should be 1.5 to 2.5 times normal. So you check every 6 hours until stable. Activated partial thromboplastin time. That is the full name of the APTT. So this drug is normally given through IV. IV is an IV medication. The antidote for the unfractionated heparin is protamine sulfate. So that will be given to unstable clients. If you have stable clients who need heparin, you're going to give them low molecular weight heparin, which is the enoxaparin. So the treatment dose, like in the case of deep venous thrombosis or pulmonary embolism, you give an injection of enoxaparin 80 mg subcutaneous every 12 hours for 5 days. So that means that will be 1 gram per kg subcutaneous every 12 hours. Or you can give 1.5 milligrams per kg subcutaneous once daily, but this is less preferred. For prophylactic dose, you normally give 40 mg subcut once daily, 30 milligrams subcut every 12 hours for orthopedic surgery. So if the creatinine clearance is less than 30 mils per, you normally give 1 gram per kg subcutaneous OD. So this drug primarily works as an anticoagulant by enhancing the activity of antithrombin 3, a naturally occurring inhibitor of coagulation. The third drug is warfarin, which is the vitamin K antagonist. So the initial dose you give 5 mg orally once daily. Then you can adjust the dose based on the ENR. Remember, the target for the ENR is 2 to 3 for most indications. This drug normally inhibits synthesis of vitamin K dependent clotting factors, clotting number 2, number 7, number 9, and number 10 in the liver. Warfarin takes about 3 to 5 days to reach therapeutic level, and that's why we normally overlap it with unfractionated heparin or low molecular weight heparin like enoxaparin until the ENR therapeutics for consecutive days is stable. So example of prescription I think we had given, that is warfarin 5 mg once daily. Remember to check INR on day 3 and adjust accordingly. The antidote for this vitamin K and vitamin K is vitamin K, or we can also give fresh frozen plasma, right, for that rapid reversal. Another drug, anticoagulant drug, is dabigatran, which is a direct thrombin inhibitor. Notice on our right where it is working up along the coagulation pathway. So you give 150 milligrams per oral twice daily, and then you can reduce it to 110 BD if the age this guy is more than 80 years of old, or there is impaired renal clearance, or there is a high risk of bleeding. You avoid if the creatinine clearance is less than 30 mils per minute. Example, we have dabigatran 150 mg per oral twice daily. Remember, the antidote for this drug is the idarubicibab. The next group of drugs that are referred to as factor 10 activator inhibitors. So if you are giving a patient with DVT or pulmonary embolism treatment, you could give 15 milligrams per oral twice daily for 21 days, then 20 mg once daily thereafter. So it can be used for prophylaxis after surgery, where you give 10 milligrams per oral OD. This drug should be avoided in patients with creatinine clearance of less than 30 mils per minute. Examples of group of these factor 10 activated inhibitors include rivaroxaban. We also have apixaban. We also have endoxaban, and their respective antidotes. So apixaban, the same category of the factor 10 activated inhibitors drugs. So these anticoagulants, we can have them in summary form, where we have talked of heparin and fractionated heparin for the unstable patient. So we give them IV bolus, 5,000 units, then 1,000 units hourly. So we titrate it to APTT. If the patient is stable, instead of giving heparin unfractionated, you give the low molecular weight heparin, that is enoxaparin. This is given subcute, and the prescription for an adult to have 1 mg per kg twice daily. Then we have now 40 mg OD for prophylaxis. You remember to adjust if there is renal impairment. So for the other drugs, the oral one, now we have the warfarin, which you give 5 mg OD and you adjust per the INR. Remember, you have to overlap it with the heparin, and also to monitor the ENR to be between 2 to 3, which is the target. We also have the dabigatran, which is you give the patient 150 milligrams BD. You also have the rivaroxaban. You give 15 mg BD for 21 days, and then 20 mg OD. Then we have apixaban. You also give them orally, that is 10 mg BD for 7 days, then 5 mg BD. You remember to adjust it for age, weight, and also renal function. So we have several indications for use of this anticoagulant, and you have to always balance the benefit of the clot prevention vis-a-vis the risk of bleeding. One of the first indicator for this anticoagulant therapy is the venous thromboembolism, which involves DVT and pulmonary embolism, and in this case anticoagulant is used to prevent clot extension or recurrence. The second one is atrial fibrillation. Here, the drugs are used to reduce the risk of stroke by preventing clot formation in the atria. The third indication is mechanical heart valves. Warfarin is preferred to prevent these valve-related clots. The fourth one is post-operative prophylaxis, especially after orthopedic surgeries like hip or knee replacement. These drugs are used to reduce the risk of DVT formation. The fifth one is MI, myocardial infarction, and in selected cases, anticoagulants normally are used to help prevent further thrombolytic or thrombotic events. The last one is DIC, disseminated intravascular coagulation. So here we use unfractionated heparin is used when thrombosis dominates. So these drugs are very important. They'll be used to treat a number of conditions, but they are contraindicated in some conditions, and this is mainly due to high risk of bleeding or complication. Like the first one, active bleeding, anticoagulants can worsen ongoing hemorrhage or prevent clot formation, like for the case of peptic ulcer disease conditions. The second one, we have hemorrhagic stroke. In this case, you find that anticoagulants increase the risk of rebleeding in the brain, which can be fatal. The third one is recent surgery, especially the one affecting the CNS or the eye. You find that these areas are highly sensitive, and anticoagulation can lead to life-threatening bleeding post-operatively. The fourth one is severe thrombocytopenia. So with very low platelet count, even minor anticoagulation could lead to uncontrolled bleeding, hence should be avoided. High BP raises the chance of spontaneous vessel rupture, particularly in brain bleeds. So that means we need to avoid anticoagulant in such case. And lastly, for the liver disease, especially with warfarin, you find that the liver damage affects clotting factor production and drug metabolism, and this leads to high bleeding or overdose risk. So anticoagulants are very effective, but also have normally come up with some side effects and adverse. The first one is bleeding, and this is the most common and serious risk. It can range from minor bruising to life-threatening hemorrhage. Heparin-induced thrombocytopenia is a rare but dangerous immune reaction to unfractionated heparin that lowers platelet count and paradoxically causes clotting instead of bleeding. Osteoporosis is seen in long-term heparin use, especially in pregnant or hospitalized patients due to its effect on bone metabolism. Warfarin skin necrosis can occur. It's a very rare complications where the skin tissue dies due to clotting in small vessels, usually early in therapy. And lastly, GI symptoms, which are common with direct oral anticoagulants, the DOACs, like the rivaroxaban or the dabigatran. They normally cause nausea, ingestions, or GI bleeding. So this is how the drugs are. So when you are monitoring, remember that unfractionated heparin, you look at APTT, and the antidote is protamine sulfates. For the stable patient, we normally give them low molecular weight heparin, the enoxaparin, and here you look at the this one is you monitor the anti factor 10 activated. Of course, the antidote here is protamine, but partial. Then we have warfarin. You monitor the INR. The target is usually 2 to 3, and the antidote is vitamin K. Then we have the dabigatran, rivaroxaban, and apixaban. So you find that this one, the last three drugs, they have one advantage over warfarin in that they don't require continuous monitoring. So warfarin, you have to monitor and find and see that the INR is between 2 to 3. Lastly, the nursing consideration. The nurse needs to monitor for signs of bleeding, especially in the gums, in the urine, in the stool, the bruising. You also need to educate on bleeding precautions. So there'll be no contact games for such patients, right? And and also you encourage them to use soft brush so that they can avoid or minimize the risk of bleeding. You need to monitor the blood, the lab values. We have talked of ANR for warfarin, and we also have the APTT for the unfractionated heparin. Also need to avoid NSAIDs and other drugs that can increase bleeding risk, and teach the patient on warfarin to maintain consistent vitamin K intake. Lastly, you need to monitor renal function in patient with the DOX, right, like the rivaroxaban, so that they are able to have the appropriate amounts that the kidney is able to eliminate comfortably. So has been the presentation on anticoagulants. So remember, we have talked of the different types of anticoagulants, and we say that we have the parenteral anticoagulants and the oral anticoagulants. So the parenteral anticoagulants, we have talked of the major one, which is the unfractionated heparin, and that is for these unstable patients. But for the stable patients, we normally give them the low molecular weight heparin, like the enoxaparin. So as we do that, we transition them to the oral anticoagulants. So the most common one used is warfarin. So, and when you're giving warfarin, you have to overlap it with heparin. So after heparin has the NR are stable, then now you can comfortably continue with the warfarin. Remember the direct oral anticoagulants, like the rivaroxaban and the dabigatran. They have one advantage over warfarin, in that for them they don't require INR monitoring. Thank you so much. Let's go through that and compare it with the pulmonary embolism or the use in the DVT to see the difference.